Hi, everyone. My name is Mark Schwartz. I'm a grad student at the University of Virginia working with Dr. Rich Price. And today I'll be presenting my work on the impact of vascular normalization on FUS-mediated drug delivery in our murine breast cancer model. To start everything off, I will begin with an overview of relevant background to my project. I'll move into my characterization of breast cancer blood vessels in our 4T1 tumor model. I will then continue with a model drug measurement system I built out to assess and quantify drug delivery with the help of FUS ultrasound, and will follow everything up with some directions I'd like to take this project going forward. Now, the clinical problem I am addressing here is the question of efficient drug delivery in solid tumors. We know that most anti-cancer drugs are systemically administered, and yet there's insufficient passive delivery via the enhanced permeation and retention, or EPR effect. This results in limited drug dosing due to inefficient delivery and results in unwanted patient side effects. A natural question stemming from this clinical problem is, how can we improve drug delivery then to solid tumors? One delivery tool that we can leverage is mechanical focus ultrasound, which many of you may be familiar with, wherein in our case, neutral lipid shelled microbubbles are injected intravenously. Ultrasound at a low peak negative pressure is applied, and the microbubble begins to cavitate, interacting with the walls of the blood vessel passing through and causing temporary vessel disruption. When a systemically administered therapeutic is also injected, there is an increase theoretically in this therapeutic being delivered across the endothelial barrier due to transport mechanisms. A second delivery tool we would like to take advantage of in this project is vascular normalization, which, if you're not familiar with, this term was coined in the early 2000s by Dr. Rakesh Jain. He posited that lower instead of higher therapeutic doses of anti-angiogenic therapies might be capable of temporarily changing the way that tumor blood vessels behave. And to illustrate how this might intersect interestingly with focus ultrasound, I'll paint a picture with a standard tumor blood vessel. Here you notice that there are cavitating microbubbles within a vessel. We can assume that this is within the sonicated region of a tumor. You may also notice that these vessels have holes in their walls. This illustrates the high permeability, leakiness, and ultimately high interstitial fluid pressure that results from leaky vasculature within many solid tumors, and the unevenly lengthed arrows within the blood vessel represent unequal and heterogeneous blood flow throughout the tumor, which is another major barrier to drug delivery to the volume of a solid tumor. Upon the systemic administration of some normalizing agent, some combination of the following three phenomena may ensue. The first of which is a reduction in vascular caliber. The smaller that a blood vessel gets, to some degree, the higher the likelihood for microbubble vessel wall interactions, and also the higher likelihood of drug delivery to that region of the tumor that is sonicated. The second phenomena is a reduction in vascular permeability. This reduced leakiness may also decrease interstitial fluid pressure, a major barrier for convective delivery of drugs. And finally, we might expect a homogenization of blood flow throughout the tumor, allowing greater access of blood and therefore a therapeutic delivered through that blood to a greater fraction of the tumor. The vascular normalization paradigm that we have been employing, we have applied to the 4T1 subcutaneous murine breast tumor model, whereby we subcutaneously inject in the right flank 4T1 cells, and at days 7, 10, and 13, intraperitoneally inject a 10 milligram per kilogram dose of DC-101, which is a monoclonal antibody blocking VEGF receptor 2. And in another group, we administer similarly an appropriate IgG isotype control. At day 14, we took the mice down for histological analysis and found that, strikingly, keeping in mind that blue is nuclear adaptive stain and green is an endothelial CD31 stain, that in the IgG control treated mice, the tumor blood vessels tend to be much bigger, and these gaping lumens you may expect may result in a low likelihood of microbubble vessel interactions, which I alluded to previously. Comparatively, in the DC-101 treated tumors, there is a much smaller skewing distribution of blood vessels here, at least to the eye, and quantifying representative images from these tumors, we found that indeed median vessel area in the DC-101 treated tumors was about twofold smaller than that in the IgG treated tumors. There was also a reduction in the number of vessels per unit area, which is not unexpected since we are dealing with an agent that blocks vasculogenesis. And another third metric that we used to confirm these first two results was the total vessel area over the field of view, and this trended in a similar direction, confirming what we had already found. We wanted, however, to ensure that this agent was not causing growth control by itself when looking towards application of therapeutic agents on top of this and focused ultrasound in the future. And we found that in a larger sample of 15 mice per group, that although there was a trend towards growth control, there was not a significant growth control effect of the DC-101 treatment dose that we administered. This begs the question, how can we quantify drug delivery in these tumors, even if we've already gotten to a point where vascular normalization, at least by the metrics we used, seems to have been achieved? And I resolved to respond to this question by building out a measurement system with a model drug that I could quantify. I employed a 70 kilodalton Texas red dextrin as a model drug for one of two reasons. Firstly, because it's quite similar in size to an antibody that I may want to deliver in the future. And secondly, because its fluorescent tag makes it easy to quantify by many methods. I injected this into the tail vein of a mouse, then administered neutral lipid microbubbles and sonicated one corner of the tumor. 10 minutes later, I removed these tumors and enzymatically digested them, mechanically homogenized them, filtered them, and ultimately measured the fluorescence intensity of each sample with a fluorescence plate reader. I then compiled and analyzed these results and found that across a range of pressures, we saw an increase in fluorescence intensity of almost threefold compared to dextrin being administered alone without any focused ultrasound treatment. And keeping in mind that these groups were normalized to a sham control with no dextrin or focused ultrasound treatment, we can maybe take two different things away from these data. The first of which is we were able to confirm that focused ultrasound does in fact enhance the fluorescence intensity of these tumors with dextrin delivery, which indicates that FUS is increasing the dextrin delivery in these tumors compared to passive accumulation. And secondly, this assay may be sensitive enough to detect differences in our DC-101 normalized tumors compared to the IgG controls that we looked at earlier. And so we then answered this question of what happens when we introduce DC-101 into the system and found the results were quite interesting. So here we analyzed our fluorescence a little bit differently. We normalized to sham first and then set the baseline dextrin only group to a value of 1 and measured the fold over that dextrin only group as an augmentation of FUS with the amount that was delivered in that group. So we see here a quite modest increase with the layering of FUS on top of dextrin. However, we see a much higher fold increase in dextrin delivery compared again to baseline of DC-101 alone. And this leads us to believe that perhaps the DC-101 pretreatment of these tumors allows a higher propensity of these tumors to have elevated delivery after focused ultrasound or during focused ultrasound treatment. Moving forward with this project, I'd like to further optimize FUS parameters for greater delivery of this drug to a higher volume of the tumor. I'd also like to assess if increasing delivery, as we are showing here, correlates with growth control with the application of some sort of therapeutic agent. And I'd also like to better understand other normalization effects that were not enumerated in this presentation on tumor blood vessels. With that, I'd like to thank my lab and all of its members for not only making this work much more possible, but also much greater pleasure. And I'd like to also acknowledge our funding sources for making this work financially possible. If anyone has any questions for me, please feel free to engage over the FUS Symposium website or reach out to me in person. Thanks.